What about long-term survival? There's lots of paper out there that show excellent results in long-term survival with total knee replacement, such as these papers by Callahan, Insall, and Malkani. But there's also papers out there that show that there's some early failures. This is a paper by Pignano, who has looked at 25 revisions after a mean follow-up of 2.8 years. And their conclusion was that there was a mismatch in flexion-extension balancing with sort of a mid-flexion instability that required revision of the femoral component, as the ones that had a poly exchange did not do very well. This is another paper by Faring that has shown that early revisions, which is less than 5 years, of 440 revisions, 27% of those patients had instability, and there were other factors of failure as well. And in this last paper by Pete Sharkey, again, you can see that instability, polyethylene wear, and aseptic loosening were the causes for early failure in less than 2 years after knee replacement. Well, let's talk a little bit about alignment. The old Hungerford picture that we're all so familiar with when we go through our residency program. There are 3 axes, 6 degrees of freedom. There's flexion extension, varus valgus, and internal and external rotation. Then most of us put in 3 components, a femur, a tibia, and a patella. Let's make an assumption that each component has 1 correct position and 2 incorrect positions. That gives us 36 possible malalignment for a single total knee. When you do the math, 36 factorial, that's nearly 11,000 combinations for misplacement in a total knee. So a pretty frightening statistic. So how do I deal with the bone and the soft tissue? When I look at the way I do a knee replacement, there are dependent and independent bone cuts, and the soft tissue balance can be achieved by either releasing soft tissue or by using a dependent bone cut. Now let me explain. We have an extension gap and we have a flexion gap. The extension gap are independent cuts. Your distal femoral cut and your proximal tibial cut is done independently, and I do it with computer navigation. You then follow by making it rectangular by doing soft tissue releases. Now, your flexion gap, if you do further soft tissue releases to balance that, you may affect your extension gap. So this is a dependent bone cut, so your femoral rotation can be used in order to balance your flexion gap. So again, soft tissue releases in extension, and the soft tissue balancing in flexion is done by femoral rotation, and we use the eLibra for that. It's a very nice device. It has a sensor plate, so it gives us not only tactile feedback, but also numbers that we can use in order to balance our soft tissue. We go into extension, put in a polyethylene to fill the extension gap, and then we use that same thickness of polyethylene in flexion. We reduce the patella, and one of the beautiful things about this is that you can check your patella tracking before you determine what your femoral rotation should be. And then we adjust the femoral rotation to balance the flexion gap. So I call that the art of total knee replacement.